afternoon or good morning, everyone. Welcome to AIC's webinar. My name is Zaibo Li. I'm a pathologist and a professor of pathology at Ohio State University. I'm also a member of AIC Executive Board. I'll first start with some housekeeping rules for today's presentation. All members of the audience will be on mute and cameras will be off. We ask that you enter questions in the chat window and we will have a QA session at the end. Since this is a corporate webinar, no CME will be available. Now it's my pleasure to introduce today's speaker, Dr. Sara Monaco. Dr. Sara Monaco completed medical school at Columbia University, where she stayed as a resident in anatomic and clinical pathology. She then completed her training, including cytopathology fellowship, and stayed on the faculty for over a decade at University Pittsburgh Medical Center. I have to mention that Dr. Monaco was my attending and fellowship director when I was training in Pittsburgh. In 2020, she transitioned to Geisinger Health System in Central Pennsylvania and is currently the division chief for cytopathology and Northeast pathology, in addition to professor of pathology and program director for the cytopathology fellowship. At UPMC, she was one of the early adopters of telecytology and then implemented telecytology at Geisinger in 2021 and was a part of AIC telecytology validation task force. Dr. Monaco's career has included publication of many peer-reviewed articles, book chapters, and 4 co-authored books in cytopathology area. She has also presented several educational courses at national and international meetings, including AIC, USCAP, and IAC. Currently, she is on the AIC Executive Board and serves as the president-elect of AIC and associate editor for JASC, the Journal of AIC. Now let's welcome Dr. Monaco.
Thank you, Zaibo, for that nice introduction. And I wanted to thank the ASC for inviting Dr. Li and I to give this webinar today on a topic that I think is of interest to a lot of our cytopathology community, as we've discovered through surveys that the ASC has done. I also want to thank Grundium for their support today of this educational webinar. So I'm going to, share today my experience with rapid on-site evaluation and particularly using novel technology to do telecytology. I think this is a topic of interest that we've identified through our ASC surveys that a lot of our community is interested in. And it was nice to see that over 500 people are registered for today's webinar. So I think we hit a topic that is timely and of interest to a lot of our cytopathology and other pathology community. I'm going to turn my video off here. And so I'm going to really focus today sort of as my role as a practicing cytopathologist and how my current institution is really leveraging the technology to help us with increased access to cytology services, particularly in our rural healthcare system, with an expanding use for small biopsies and limited lab staffing. I have no conflicts of interest with respect to today's talk. I am a user of Grundium devices at my institution, and Grundium has provided a special educational grant to the ASC to make this webinar possible. So sort of our educational objectives today is to see how we can approach rapid on-site evaluation by telecytology, particularly using novel technology in the field.
Join the meeting.
Scan rows, slides, or to use robotic microscopy in addition to live video streaming. And we're also going to sort of assess how you can approach rows with technology based on the staffing and clinical needs at different sites or institutions, and then sort of understand sort of the impact of recent regulatory changes on telecytology. So I'm going to summarize some of the ASC survey results, particularly those addressing telecytology. Then I'll move on to sort of a real world lab management issue like I've encountered in practice regarding ROSE coverage. Then I'll move on to sort of discuss issues to consider with implementation of telecytology for ROSE. And actually, I've incorporated a video today that takes you through sort of a ROSE encounter that I've had um, using robotic microscopy and whole slide or partial slide scanning. And then we'll move on to a question and answer period that we've saved time for today. And Dr. Li will moderate those questions at the end. And as he mentioned, you can enter them into the chat. Okay, so let's get started. So in 2019, ASC did a telecytology ROSE survey, um, and basically that showed the majority of cytopathology practices were offering rapid on-site evaluation, but at that time only about 22% were utilizing telecytology for ROSE. Now remember, this was pre-COVID, but I will say this survey had over 500 responses to it. It was one of the most sort of well-responded surveys that we've had as an organization. And if you look at our ASC membership, about 20% of our membership responded to this survey. So I feel like that number was probably pretty accurate. In addition to the time spent, we kind of characterized that with over half of the cytopathologists spending more than 30 minutes per ROSE evaluation. But even more remarkable is that 86% of cytologists spent more than 30 minutes per evaluation. And so if you consider a half hour is about 6.25 slides that they can't screen because they're occupied with ROSE. And so that is a huge time investment, and you have to think about that when you are using cytologists to support ROSE. So now let's fast forward. Now we have survey results more recently from 2025. So if we take that 22% in 2019 pre-COVID, we now know that about 44% of respondents are utilizing telecytology for at least a subset of ROSE procedures. So basically, utilization of the technology has doubled in 6 years. And we know the pandemic has definitely kind of sparked that interest and motivated people to use more technology, but that's a pretty significant increase. Furthermore, we know that most laboratories are scanning slides more for surgical pathology than for cytology. And even if you look at whole slide scanning, we do it much more for frozen sections. So about 37% of surgical pathology practices are using whole slide imaging for frozen sections, which are another way to sort of give preliminary impressions. And only about 11% of cytology practices are using digital cytology or whole slide imaging for rapid on-site evaluation. So if you look at that and you say 44% are using telecytology, only 11% are using digital cytology and whole slide imaging. So the majority of people are probably using live video streaming or maybe some more robotic options. And my goal today is to kind of show you some of those robotic and more whole slide imaging options that are not being as widely used as they are in surgical pathology. Another survey that the ASC did showed that telecytology for ROSE was now considered one of the best applications for digital scanning, and is one of the most common applications that pathology labs are using now in cytology. And I think it's kind of really interesting to look at this graph on the bottom here, and you can see these are people's complaints about using telecytology for ROSE, and the blue bars are what we considered disadvantages or problems back in 2016. And the orange bars are now the problems that we foresee in 2023. And what you can see here is that early on, we felt it was technically difficult, that there were poor image quality, it took too long, it was hard to screen and hard to focus. But a lot of that has gone down now that we have better technology and things have gotten better. So now it's not as technically difficult. The image quality is not as poor. It doesn't take as long, or it's not as difficult. And now we're kind of talking about sort of remote operator dependence. Are you dependent on someone live streaming for you? Is the communication challenging and things like that? So I think this really kind of encompasses how our perspective and practices have changed as the technology has gotten better. And maybe you could say we as pathologists have also gotten better using that technology and understanding it. So this table just kind of goes through a variety of sort of advantages and disadvantages with rapid on-site evaluation and using telecytology. I will say we know the advantages are that it allows cytology labs to sort of meet the increasing demand for rows. We know that it's faster, easier, and cheaper to move that image than the actual pathologist. But despite the advantages, there are still challenges. Like you need to have on-site staff that are good in making slides. You need a financial investment. And then there is a lot of sort of reluctance due to technophobia and people's sort of lack of familiarity with the technology or perceived disadvantages, that it's too slow or you can't get it to focus, and things like that. But I will say technophobia is not just on our side in pathology. I would say it's also on the clinical team side. I've had clinicians tell me that they want to look me in the white of my eye to know how confident I am in my preliminary adequacy impression or things like that, or they just want to talk to me about the case. And I think there's a perception that once the pathologist is remote, you kind of lose that communication. Um, this is just showing you on the right-hand side after we implemented telecytology at Geisinger, I did get a sort of secure message from one of my radiologists kind of commenting about how cool it was and how excited he was about it. And so I think that shows kind of a shift. This shift takes time. There's technophobia on both sides within pathology and in the clinical team side in sort of letting their pathologists be remote. And this can be overcome with sort of good technology, good communication, but it does take time. I will just mention, in terms of quality initiatives, I think, a lot of hospitals now are trying to have increased kind of quality goals for their healthcare system. And I think when you think about the small biopsy acquisition stage, when you have like radiologists and pathologists and the entire sort of cytology team working at the patient's bedside while they're having a biopsy, you have this unique opportunity to kind of correlate real time and to change the management at that time for that patient without coming back for a repeat biopsy. Maybe the radiologist pivots and does a core biopsy. Maybe they do more FNA passes for the cell block. But this sort of interplay between the diagnostic teams based on the clinical impression and the order from the clinicians really kind of highlights this unique opportunity for healthcare organizations to have sort of direct collaborative interactions. And this is one of those questions on one of the quality surveys put out by the Leapfrog group. And I think as we all try to approach quality initiatives, I think rapid on-site evaluation and support for this initiative is sort of one way to address questions like this. So let's talk about access to rapid on-site evaluation, because this is one of the problems I've had in my practices as a practicing cytopathologist. So one question you have to say, is there an unrealistic travel time separating your pathologist from the biopsy site? This may be like a long driving distance in my rural healthcare system with lots of fields and distance between my healthcare systems. But it could also be traffic if you're in a big city. In addition, a lot of hospitals are adding new towers or expanding the footprint of their healthcare system, and it may make sort of a long walking distance to get to those biopsy sites. And so being able to move that image without moving the pathologist can be a huge time savings. Then you have to say, like, does every site need telecytology? Like, should you sort of adopt technology um, universally in your healthcare system? Well, it could be that some facilities are small enough that access to the procedure rooms is easy and they want to just walk there and do in-person rapid on-site evaluation. You may not need technology if the rows volume is not burdensome. And then you have to ask yourself, like in sites where you don't have pathologists on site, but you are having biopsies that occur, does the health system want every patient in any facility getting a small biopsy treated the same? And I'll go even further than that. A lot of our clinical providers that do the biopsies not only practice in one of our sites, but go to travel to multiple different hospital facilities to do biopsies. And maybe they expect the same level of support, whether from the cytology team if they're at the main campus versus an ambulatory care center or other hospital. So these are all questions you have to sort of assess in your own system to see how widespread to use the technology. Um, and then you have to say, should every site have the same technology? Should it be standardized? I think in some perspectives, yes, it may be easier for training. It may be ideal to deal with just one vendor. But I think on the no side, you may have existing resources at certain sites that allow you to do frozen sections, and you can use that same technology for rows, or you may have different staff necessitating different approaches. So perhaps you have cytologists at some facilities and not others, or trainees, and they can help with rows at some sites, but maybe you don't have good people with morphology skills at all of the sites to do this. And so how can you approach that? So I think these are kind of the big questions I've had to address in my rural healthcare system, but I think everybody should ask these questions if they are providing row services and thinking of transitioning to technology with telecytology. So let's look at sort of the main modalities to deliver telepathology services. So we have live video streaming, we have like robotic microscopy, and then slide scanning. And I'm going to go through a variety of different things that you can consider with these three different modalities. So the size, usually with video streaming, it's a small camera attached to a microscope. And so you're limited by the size of the microscope. Robotic microscopes are variable in size. They could be the same size as a microscope with just robotic attachments to it, or it could be smaller. And then a slide scanner can be variable depending on the slide capacity. So larger or more slides that you can scan, the scanner is probably going to be larger. In terms of cost, we know that sort of video streaming, simple camera is usually very low cost compared to robotics and slide scanning, which usually have a higher cost. The on-site personnel with microscopy skills, like a cytologist, would obviously, be really critical if you're doing live video streaming because you can only see what they are showing you. So you really need to have good morphology skills in that setting. Whereas the on-site person for robotic microscopes and slide scanners really doesn't have to have great microscopy skills. They're simply loading a stained slide, and then you will take over as the remote operator. Because you have somebody with microscopy skills with video streaming, usually there can be less evaluation episodes. If multiple slides come at a certain time, they can kind of pre-screen them and kind of self-select the better slide to show you to get to adequacy faster. Whereas if you're in basically a stain and load mode for robotic microscopes and slide scanners, where the on-site person is not reviewing that slide, you may have more evaluation episodes and you're looking at each slide in sequence as it's prepared. So let's look at a few other things. So in terms of ability to review the slide unassisted, obviously with live video streaming, you're limited by what that on-site person shows you. So you really can't review the slide unassisted. Whereas with robotic microscopes and slide scanners, the remote pathologist like myself can actually review that slide while the on-site person is staining or preparing a slide or doing other on-site responsibilities. The speed with live streaming is usually faster. It's a kind of an immediate camera connection or a Teams call, whereas the speed with robotic microscopes are moderate, sort of intermediate with a lag, and maybe if you're waiting for a slide to scan, it's slower, and that time will depend on the percent of the slide coverage and how much material you're scanning. Ability to view the entire slide. So it's possible that you could look at the entire slide with live streaming or with a robotic microscope. Usually it's not practical because of the time spent. Whereas with slide scanning, if you did scan the entire slide, you could probably move around that entire slide like you would on a glass slide pretty fast. And then, finally, for the remote user involvement, so me as a practicing cytopathologist doing rows, live streaming is very passive. I'm just kind of watching what they show me. But with robotic microscopes and slide scanners, it becomes a very active process, such that when the on-site person is busy making slides from an additional pass, I can still be looking at that slide, scanning, or moving around and sort of further evaluating what I have on that slide. So it's a very active process, and you are in control of what you're looking at. Okay, so let's look at a Rose episode. When I was at UPMC in Pittsburgh, we published our initial sort of paper on our experience with rapid on-site evaluation back in 2019. And basically we divided the ROSE episode into three components. One was travel, one was the actual read time on the slide, and one was the wait time between passes. So obviously if you're using live streaming or robotic microscopy and slide scanning, the travel time goes away because you as the remote interpreter are not physically going to the biopsy site. So then we have to look at the read time and the wait time. So for read time for live streaming, it's simultaneous, it's real time, it's very passive for the remote person, and it's usually very brief because that on-site cytologist is showing you the few regions of interest that are high yield and diagnostic. Um, Whereas on the robotic microscopy and slide scanning side of things, the remote person is driving and viewing. It's much more active, and can take a longer time. But I think what the biggest difference is the wait time. So during the wait time, when you have a robotic microscope or slide scanning, you can independently review that slide in between passes, when the on-site person is staining or preparing slides and when they're busy, and take that burden of the simultaneous real-time viewing off that on-site person. In situations where you have the advantage of having two people on site, like if you have a cytologist with a resident or fellow, that person could be showing you more of that slide in between passes. But realistically, in a lot of situations now where we're short-staffed, it's one person on site. And so you really are just waiting in between passes with live streaming, whereas you can be doing a lot more if you have a robotic microscope or a slide scanner. So let's look at a real life scenario like I've had to deal with in my job. So a hospital administrator comes to you as the cytopathology lab director to inform you they've hired a new interventional pulmonologist that will be performing EBUS transbronchial needle aspirations and will need ROSE services. The hospital unfortunately has no cytopathologists or cytologists on site, and the facility is located 1.5 hours from the main hospital. So you scratch your head and you say, how do I manage this? So this is just kind of a demonstration of kind of what I'm talking about. A hospital A has sort of resource-rich setting with cytologists, cytopathologists. It's high volume, whereas hospital B has no cytologists, no cytopathologists, and is really much more low volume. And I think your options in this case come to like three main options. Do you hire a pathologist or a cytologist for this hospital B? Do you share a cytologist or a cytopathologist between hospital A and hospital B for some days or some weeks of the year? And then do you introduce some sort of device or technology that allows you to do ROSE at hospital B without having a cytologist or a cytopathologist on site? Um, on the bottom half of the screen, this basically illustrates kind of these two facilities. So imagine that they're connected by the same lab information system, and ROSE is available at both. And all of the specimens, all of the slides are getting couriered to the main hub, where there's consolidated histology and immunostains. And so all you need here is you need some sort of device in order to accomplish the ROSE and get that image moved to the site of cytology team at hospital A in order to accomplish that goal. Another thing I'll just mention from this slide is that, frozen section in my hospital system is not as widely available as ROSE. So we actually provide rapid on-site evaluation at more of our facilities than we do frozen section. And it could be that a lot of lesions now are being approached in sort of an ambulatory care center with cytology, small biopsies, FNA, and things like that. And so the ROSE offerings are typically more extensive than the frozen section offerings, particularly at sort of these low volume ambulatory care biopsy sites where they may have interventional radiology, but maybe not operating rooms and things like that. So just other things to consider. So this is how we accomplished this. We looked at hospital A and hospital B, and we decided to use technology. Considering hospital A is very high volume and there's a huge footprint in our hospital system where the biopsies happen, lots of distance to travel. We basically send our cytologist and we do live streaming. So the cytologist or the trainee is on site and the pathologist is remote using live streaming. Hospital B, we do use whole slide image scanning, robotic microscope, a little mini slide scanner. And we actually have medical laboratory scientists or lab techs on site that can prepare the slides, stain it, and load it on this device so that we can remotely control that robotic microscope or scan the slides to perform rows. So 2 hospital systems, both giving row services, but doing it in a very different way in terms of technology and staffing. This sort of highlights throughout the system, we have live streaming at some of our facilities and the robotic microscope or slide scanning, but we actually also have some facilities that are still in person because the footprint of the hospital is much smaller and the pathologists find it easy to go to the biopsy sites. So I think, sometimes a hybrid approach in using technology when you need it, but not universally, can work for different facilities based on your staffing. I will just point out a couple of other things, in terms of technology, yeah, you can look at, your cameras and your robotic microscopes or slide scanners, but consider other things. We have these Bluetooth wireless earpieces that our on-site personnel can use. And this is really great because they are seamlessly connected to their remote pathologist, while the patient and other operators in the room cannot hear exactly what we're talking about. So that really is kind of a seamless way to have communication that's easy and discreet and that not everybody can hear. But you can also kind of use speakerphone and things like that if you're in an area where the radiologist may want to communicate. The other thing is that phones are really critical. We use the hospital iPhones to basically communicate between on-site and remote personnel routinely. With secure messaging, you can be sending labels and things like that to confirm identifiers, which is really critical. So I just shared kind of how we approached rows in these different scenarios, but other organizations have done this differently. This is one paper from Memorial Sloan Kettering. They actually have the radiologists on site preparing their slides and staining it and loading it for the remote cytologist to use a robotic microscope to evaluate those slides for rows. So here's an example where we've kind of removed the lab staff on site and still provide the row services with a remote cytologist. And this can be another way to kind of approach this. I will say a few things about this approach. Some institutions have struggled with this because of sort of unions or limitations of who in the room can actually do the slide scanning. Some people don't feel comfortable preparing the slide if they're not lab staff. So think about unions and training that lab, sort of the on-site personnel, whoever it is, but particularly if it's not a lab staff. So let's talk about if you are using robotic microscopy or whole slide scanning, what it kind of looks like. The on-site person will prepare the slide, they'll stain it, and then they'll load it on the device, and you as the remote operator can sort of take over from there. This is an example of a touch prep slide when I think most times touch preps do not have extensive slide coverage. So a lot of times it's just a small portion of the slide that's covered with material. And in this scenario, it's usually very easy to sort of designate a region of interest and scan it. So you can see here, if I wanted to scan the gray area to encompass all of the material, it would take about 1 to 2 minutes. But let's say I just want to scan a little area, sort of the green annotated box here in the lower left-hand corner will tell me that that will be 37 seconds to scan that area. And maybe that'll be enough for adequacy. And so in 37 seconds, you can have your little scanned area to evaluate. This may be not so easy if you have sort of non-diagnostic, bloody, hypocellular cases, particularly with thyroid or endobronchial ultrasound-guided specimens, where you have much higher slide coverage. So let's look at what that would look like. So this is an example of a slide with a lot of slide coverage, where you're looking at sort of a high area of coverage, and you're saying to yourself, okay, how am I going to approach this with whole slide scanning and robotic microscopy? So I'm going to point out a couple of things here. So at this sort of and when I log into this scanner, I can see the label. it's hidden today, but the label allows me to sort of visually confirm identifiers and to confirm the source. So I know that, okay, this is a lymph node, FNA, and they're concerned about a possible lymphoma. And so I can confirm identifiers and the source. And then let's look at some of the buttons that I can see. So first, I can see the live view mode here if I want to use the live robotic microscopy. I can also have a scanning button here. In the upper right-hand corner, I have a low-resolution thumbnail image that allows me to see where I'm navigating in the slide. And in the left-hand corner, I have magnification, so I can kind of move into low power or high power, or I can use my mouse. So I'm going to move this into sort of a video mode. The video is actually sort of a real live Rose encounter that I did. And so hopefully it'll give you a sense for how the pathologist approaches the remote evaluation. But I will just say, like, the resolution is not optimized for the webinar format. This is really just a video of my screen as I'm doing Rose. So I'll just mention that. But here I will go. I will just mention one more thing. The green line that happens around the edge when I load the slide, that is basically the automatic tissue or material detection. And so it will draw that line automatically. And in the lower left-hand corner, it would tell you how much time it would take to scan that entire slide. Here, it would take about 7 minutes to scan that entire slide. So I'm going to remove that line, and I'm going to show you how I evaluate just fields or regions of interest. So here you can see I remove the green lines, and now I'm kind of looking at the thumbnail and deciding how I want to approach this. So I find an area in the upper left that I want to look at. I'm using my mouse to kind of scroll into high power. The autofocus is on, so it's automatically going to try to focus in the region that I've selected. Once it's focused, then I can kind of move around with my arrow keys or my mouse. I can even open and expand that high power window to see that this looks like a small round blue cell tumor, to triage for flow. And it's pretty good resolution for moving around at high power. Now let's say you can see in the thumbnail that I'm sort of on the left-hand side. Now I've jumped to the right-hand side because I want to look at different areas to get a sense for the overall cellularity. I can easily move that box back and forth from the left to the right-hand side to see different areas in higher power. And each time I go at high power, it will focus. Now let's see what happens if I want to stop live view. And now I'm going to sort of add a region of interest that I want to scan. So I'll delineate the region I'm interested in. Then I'm going to move to high power. It says that that box is going to take 16 seconds to scan. And so I'm going to sort of get that area. Once it's ready, it will be sort of a high resolution scan section of that slide. And you can see the demarcation between the lower resolution thumbnail and then this high resolution area I scanned. This is much easier to kind of move around between low and high power because it's not automatically focusing as I go in and out. And then once I'm done with the episode, I can then sort of change the slide and eject this slide, and my on-site operator can then load a new slide. Okay, so let's talk about sort of how Rose or prelim impressions and triage differs from final diagnosis. You know, for when we're just trying to sort of give a preliminary impression, sort of triage that tissue, we're looking at a portion of the material. You want just good enough resolution. It's going to be slower than reviewing the glass, but it's going to be faster than if you scanned the whole material, if you just choose or review a region of interest. And there's no storage requirements, which makes it a lot easier. For final diagnosis, obviously, if you're doing primary diagnosis digitally, you want all the material, you want the best resolution. It's going to be slower and you're going to have storage requirements. But I think this kind of highlights sort of the differences between implementing technology for Rose versus final primary diagnosis. This is a great table that kind of talks about the quality factors that impact glass slides and digital slides on the left, and then quality factors that you have to think about only in the digital setting. And this is from the American College of Veterinary Pathologists, who actually do a lot digitally. And so I'll just highlight, you know, some of the things that impact both glass and digital, or sort of low cellularity cases, necrotic cases, cases that have a lot of background debris that obscures the cells, or a thick or clotted specimen. But then you have to add on all of these factors that affect digital image quality. So incomplete area of scanning, lack of focus, insufficient fine focus, brightness or contrast issues that make real-time adjustments difficult. And so when you think about it, digital images have all of these things mentioned here as potential quality factors. The other thing I will mention is that garbage in, garbage out. If your glass slide quality is bad, your digital image quality and is going to be very challenging. And so I think this kind of highlights how important it is to kind of train your on-site personnel to really make great slides, to not excessively manipulate cell blocks, and to um, have smears that are well prepared. Okay, so now that we've talked about image quality, I think it's important to kind of know the settings on your devices when you're using novel technology to see how can you optimize your digital image, um, and sort of get it optimized for your viewing to be able to do ROSE. And a lot of these devices may be optimized for H&E stains, not DiffQuick or another stain that you're using for ROSE. So it is helpful to know where the adjustments are. And the things I frequently think I'm optimizing when I'm looking at DiffQuick slides are gamma, red gain, blue gain, and color temperature. And on the device that I was using during the video, if you look in sort of the high power window, there's a plus minus. When you click on that button, a lot of the adjustments that I use appear, and you can easily do that during your during the time that you're doing a ROSE or other evaluation. So, telecytology for ROSE does not come without its challenges. There are challenges for the on-site operator, and there are challenges for the remote reviewer. On-site, I think you have to think about how you're going to travel to the biopsy site. Are you going to put a slide scanner on a cart, and then your on-site staff has to wheel it and go on elevators and avoid staircases? Whereas if you have like a permanent setup in the locations that you frequently go to, then perhaps your on-site person can go up and down staircases with a little basket, which may make it easier. There's also stress with like making high quality slides, showing the cells of interest to the pathologist, troubleshooting technology on the fly when things don't go right, relaying messages between your pathologist who's remote and your proceduralist in the room, dealing with more requests and doing sample triage, labeling of slides, and just organization overall. On the remote side, there are also challenges like keeping track of the paperwork if you're doing the ROSE documentation remotely, dealing with simultaneous procedures, losing track of what you did before you were on ROSE, were you already in a case, signing out a different case, and picking up where you left off, covering other duties and finding coverage, like when you're covering tumor boards, having challenging morphology cases, like when you have a few tumor cells in the background of lots of benign cells, or when you're not sure what you're looking at, that can be also a stress. And then fear of missing out. If you're not reviewing everything on the slide and things are a little slower than you would navigate on a glass slide, perhaps you feel like you're missing out on part of that sample. And then there's always the pressure to give results quickly. So let's talk about the validation, because I think the validation time is a time when the entire team involved with telecytology can really get comfortable with the technology and really play and figure out all the ways to optimize the workflow. When you are doing the validation, you really need to have the entire system validated between the on-site equipment, any software you're using to transmit the images, any telecommunication link like the internet and Wi-Fi access, and then your remote workstation. And don't forget, for communication purposes, the secure messaging on phones, whether you're going to have Bluetooth, wireless earpieces, and things like that. So luckily for us, there are lots of good sort of articles out there that can help you with uh, with figuring out how to validate for telecytology. There are guidelines from multiple organizations, multiple task forces. The one I'll focus on is the one published in JASC by the ASC, which had basically a year-long task force dedicated to telecytology rows validation. And I'll point out a few things of importance here. You really need to validate the entire system. You do need personnel training before participating in rows, and this really needs to be documented. There actually is a lab general CAP checklist item for whole slide imaging that actually asks for the training checklist for all personnel involved. The validation study should really mimic your clinical environment in terms of the cases that you see, the types of preparations, if you're doing touch preps and smears and things like that. The minimum number of cases for validation really should be 60 cases, and your concordance should be higher than 90%. And I will highlight that you really need a QA program to sort of track errors and look at discrepancy trends. And I'll focus on this in a little bit more detail. When we do the correlations for the validation and for the prospective QA going forward once you are live, I think people are challenged the most with figuring out what's a major versus a minor discorrelation. So I'll go through some of the common ones that we see. Probably the most common discorrelation is when you have a prelim rows interpretation that's non-diagnostic and your final diagnosis is upgraded to an adequate sample. And that's really considered a minor discorrelation because basically no repeat biopsy is needed. And actually rows probably helped in terms of acquiring enough material for an adequate and definitive diagnosis. And this is common when you have like bloody samples or just more material acquired in the cell block in general. The less common things that we see that are major discorrelates are downgrades, and this can be an adequacy downgrade from adequate to non-diagnostic. Most of the times that could be an interpretation error, or maybe you overinterpreted benign mesothelial cells as tumor cells, or a sampling error. The other thing could be sort of a downgrade where you called something malignant, and then on final diagnosis, it's just benign or atypical. And again, that could be an overinterpretation on rows, or it could be sampling error that you actually do have tumor cells on that touch prep or smear, but there's just nothing left in the block and you really can't make a definitive diagnosis. And so these are the sort of major correlations that we see in our kind of QA that we do for rows. We actually have our lab information system as Epic Beaker, and we have really used the frozen section workflow for rows. And the way we've done this is sort of adapt the frozen versus final workflow for rows. So we look at the sort of prelim impression that's in the report, we compare it to the final at the time of sign out, and we do a QA tab that basically does the correlation. Is it concordant or discordant? And if it's discordant, is it a major or minor? And was there a patient impact? Now, if someone does not do the QA tab in these cases, there is a hard stop. So some pathologists don't like this because they have to actually complete the QA prospectively on every case before they sign it out. That makes my job as a lab director a lot easier because every case with rows will then have a QA correlation done on it, and I can pull that information monthly in reporting workbench and use those stats to look at trends and discrepancies. So let's talk about some regulatory changes. This has been a huge interest to the cytology community lately. In September of last year, CMS put out a memo basically saying that remote review of digital slides for cytology can only occur at a CLIA certified site starting in 6 months, which was March 23rd of this year. And this has been a real challenge for a lot of cytology labs because we know that like digitization of cytology slides has really helped with access to our pathology services and helped us to meet the clinical demand for rows and other pathology services, just like it's helped for decades in our for our radiology colleagues. So with the current situation, I think you have to ask yourself, is remote cytology evaluation impossible now? And so I'll just provide two perspectives. Remote isn't always home. So most of our homes do not have CLIA certificates. So I think a lot of people thought that, okay, home, a remote sign out is not possible. But I will say in my healthcare system, we're definitely doing remote evaluations. It's just from a CLIA site to another CLIA site. In addition, we've made some changes for telecytology rows given the current landscape. We have a list of our CLIA sites that are performing the biopsies on site and the list of the CLIA sites doing the remote evaluation. And I think this is particularly important if they're different, and I'll elaborate on that. We also have now put the locations for the on-site and remote evaluations in our documentation, and we have basically built up our backup coverage in case someone is not at their CLIA site who can cover that ROSE. So this is just kind of a snapshot of some of the secure messaging that we do for notification as a backup system. So if there is someone on site who needs a pathologist to do ROSE and the person that they're assigned for the day is not available, they can basically send out a secure message that I'm going to IR, is anyone available to do a rapid on-site evaluation? This will go to all the cytopathologists in the system that are at the CLIA sites, and someone can respond and say that they can do it. And then secure messaging happens just between that on-site person and the pathologist available. On any given day in my system, I'm lucky because I have 3 cytopathologists covering cytology services at any given time. So there is a built-in backup or duplicative service in order to make sure that ROSE coverage happens. We also have roles in our secure messaging that allows the proceduralist to notify us when they need cytology coverage for a rapid on-site evaluation. So I will say that the iPhones have really helped with communication from the on-site person to the pathologist, but also help the clinical teams to notify cytology. So let's see how this plays out. If we revisit the scenario from the beginning of the talk, we have cytopathologists available for ROSE coverage on site in Hospital A, but in Hospital B, we basically had no cytologists and no cytopathologists available. As I mentioned, we have pathologists available at 3 different CLIA sites. And so in Hospital A, usually it's the same CLIA site doing the remote evaluation. It's just the distance and the footprint of our hospital system just has them in different areas. So some ROSEs could be remote if a different pathologist at a different site responds to that ROSE. But for Hospital B, with no cytopathologists at that CLIA site, every ROSE will be remote from one of these CLIA sites. And so this is kind of the mapping that we did with all the CLIA numbers for all the sites for the on-site and also for the remote evaluations. So let's look at the documentation and the billing for these cases. So in Hospital A and Hospital B, our ROSE documentation in the lab information system basically will document when telecytology is used, and it will document if we're using live streaming or if we're doing slide digitization with a slide scanner. And this is really important because if you are digitizing slides, you can use the new AMA test codes for digitization of cytology slides that are not that you cannot use for live streaming or video streaming. The other thing that we've incorporated into our documentation, as I mentioned, is the actual sites. So you can see for Hospital A that does have cytopathologists on site, the address and location are the same. But for Hospital B with no cytopathologist on site, the addresses are different. Okay, so in conclusion, technology has really increased the access for ROSE services and can really improve the quality and triage of small biopsies. And I think when a laboratory decides to offer telecytology for rapid on-site evaluation, you really have to assess the available on-site staff you have and figure out and optimize the workflow when deciding what kind of technology that you want to use. Hopefully I've showed you today that telecytology ROSE is challenging but not impossible, and experience using the technology and evaluating ROSE slides is really important. And some of the challenges I've shared with you today are the staffing resources utilized for rapid on-site and other resources like time, technology, and having support and investment, financial investment. And then I think developing a plan for QA and regulatory compliance is also something that is an important challenge for cytopathology labs. So with that, I offer you to meet me and Dr. Li in Seattle when we have our ASC annual meeting this fall, and to see the technology. We have a busy exhibitor hall with all the technology available where you can actually play with the devices in person, and I think that's a really great way to connect at the in-person annual meeting. And with that, we will start a question and answer.
All right. Thanks so much, Dr. Monaco, for this excellent talk. I do see some questions from the chat. You may have already touched on some of those questions, but I think it's important to emphasize on these questions again. So the first question is, did you validate your Grundium instrument for telecytology slash rows? How did you determine cases and amount?
Yeah, so as I mentioned, the ASC telecytology rows validation recommendations recommend at least 60 cases. By the time we kind of optimized our workflow and tested it in all different sites we were doing rows, we got to over 100 cases, but you want to aim for at least 60. And so if you have, 6 different sites between interventional radiology and your endoscopy suites and things like that, maybe you're doing 10 cases in each of those sites in the same hospital to reach your 60 cases. Really to sort of mimic the entire real world rose situation with the sites and the different cell preparations you're using and things like that. So 60 cases is really like the minimum that you should be looking at for the validation.
Right. Next question is it necessary or practical to have a remote cytologist if there is someone to prepare slides and make an initial assessment on site?
Yeah, so you can have a cytologist, present on site who prepares slides, stains them, and does adequacy. If you want to bill for the rapid on-site evaluation, you really need a pathologist interpretation. So I think the value of ROSE is not sending the pathologist on site and using all that travel time and keeping them in their office and just moving the image to them. But yes, you could send a cytologist or even a lab tech to prepare slides. The cytologist could do an adequacy. And then if you want to take it even further and do an evaluation by a pathologist and bill for that, you need the pathologist tied in. Most hospitals right now, I think, are not using the cytopathologist in person for rows, but some are sending cytologists that will do everything, adequacy, staining on site. You just can't bill for that.
Right. Now let's move to next one. Do you use a 40x scanner or 20x scanner for rows? In addition, do you use a single slide scanner or full slides scanner?
Yeah, this is a good question. As the technology has gotten better, the mini scanners offer lots of options like low power scanning objective or a high power, and then different number of slides. We actually use a 20x scanner and it's a one slide scanner. Um, Back when I was validating the telecytology, the 4 slide scanner wasn't available yet. So I am jealous of practices that have that. The 20x offers you a little bit faster scanning time at the expense of lower resolution, but usually pretty good for preliminary impressions, whether that be frozen section or rapid on-site evaluation. If you were scanning using a slide scanner for like primary diagnosis, especially on cytology slides, you probably would want a higher power, like a 40x at least or 60x to scan with. Um, but yeah, if you see it and use it, the 20x it offers you a little bit faster speed with a little bit, if you're willing to sacrifice a little bit of resolution.
Good. Next one is, are the on-site staff cover sleeping the slides before viewing them remotely?
So that's a good question. So when I have cytologists on site, a lot of times they will pre-screen pretty quickly with a microscope and see which slides are the best for reviewing, and that does make the encounter go a lot faster. If you have someone like, if you have a radiologist or someone on the clinical team preparing the slides, or you have a laboratory technician who is not comfortable reviewing slides, then a lot of times it's just a matter of preparing the slides, staining it, and loading it each slide. So a lot of times they're not pre-screening and evaluating them. So I do think that, the workflow is definitely optimized when you have a cytologist on site who knows what they're looking at and things like that. But a lot of us are dealing with short staffing and a shortage of cytologists. And so figuring out what works best with your staffing in your hospital system is really critical.
All right. I believe next two questions are kind of similar. So when you have an EBUS FNA where you might have a lot of normal tissue, you may need to look at the entire slice to determine adequacy of sampling. How long would such case take you per slice, and how do you deal with that?
Yeah, so I would say for like endoscopic biopsies where we make smears, and the smears can have a lot of slide coverage, this can be challenging. A lot of times I will navigate to like three high power fields of view with the live robotic microscope and see if I can make a diagnosis and if it's like a very cellular adequate sample. For the ones that have, just the needle in the haystack, a few tumor cells with lots of benign cells in the background, that can be very challenging. So if I use the robotic microscope and didn't see clear-cut adequate cells of interest in like 3 to 5 fields, then I usually will select an area and scan it. And I may tell the person on site, like, hey, we really need more material. And while that proceduralist is getting the next pass, I actually have like 2 or 3 minutes. And most of the time, I can scan most of that slide coverage to really look at it quickly. Once you scan, like for 3 minutes, you can scan most of that material and then you're just going high power, low power very fast. I actually think I'm faster sometimes on the virtual slide than I am at the glass once it's scanned. And so it's really nice to have that wait time between passes when you're going to get an additional pass for the block anyway, and you have a little bit more time to scan and look at the slide while they're getting the next pass and then deciding, do I need to make another slide or can I sacrifice that pass for the cell block because I now realize I do have sufficient tumor cells or an adequate sample? So, as I was mentioning, that ability to be an active remote interpreter and being able to flex between robotic microscopy and slide scanning and having those options available allow you to sort of maximize that wait time between passes. And usually, we can scan most of the material. For lung cases like touch preps and things like that, I feel like we've really tried to work with our on-site radiologists to prepare, very sort of small touch preps, not dragging the material on the slide. And so the footprint of a touch prep on the glass slide is very tiny, and usually you can scan that in a minute or less. For the areas, for the smears that have much more higher slide coverage, then you're looking at like 3 to 6 minutes on average to scan when there's like more than 50% of slide coverage. Um,
Right?
so yeah, and
Great.
I think, getting used to the technology really helps. When I first started, I wasn't very fast doing this, but then after you do it for a while, you sort of like having different tools and you see what works. So I would say like if you're frustrated at the beginning with technology, you have to stick with it and kind of keep using it and learn from your friends who say, hey, have you tried this? Have you adjusted this? Or have you tried these different settings? And that can really help. But if you get frustrated and give up, that's not good. That's technophobia. You have to stick with it and keep trying.
All right, sounds good. The last question I have here is, have you used Grundium for frozen sections, and are there any differences?
Yeah, so that's a great question. We are starting a validation to do telefrozens. With the side scanner. And I will say, there's a couple of things I'll point out in terms of differences. For frozen section evaluations, you typically have more time. You have up to like 20 minutes to really render a frozen section diagnosis. So a lot of times the PAs who are cutting and staining the slide will load the slide on the slide scanner, have the automatic tissue detection, detect the border of the material, and scan. And in 3 to 6 minutes, they'll have a scan slide, and then the pathologist can be logging in to look at that scan. Once that slide is scanned, they can actually eject and load another slide for scanning while the remote pathologist is actually looking at the first scan slide. And so you do have the luxury at frozen section to have more time to sort of look at a diagnosis and usually less slides, right? Usually it's one slide maybe for frozen section. So it tends to be a little bit less time pressured and easier. And I think the frozen section workflow is much more slide scanning dependent and less robotic microscopy. But it's nice to have both options. If you wanted to do Z-stack and kind of go back and forth and kind of adjust your fine focus, the robotic option is a nice way to like go at the main area of interest and to look at fine details as you would on a real microscope, kind of taking it off autofocus and going through low and high power. So, but I would say it's much more targeted robotic microscopy for areas that you want to go focus up and down and see fine details, but most of the time it's slide scanning.
Yeah. I have to agree with you on this, frozen section using Grundium. We have been using this for several years. I do love it. Yeah. All right. I think
Awesome.
that's all the questions that I have here. Thank you again, Dr. Monaco, for such informative presentation. And thank you again.
Thank you.